For those of you in the audience, thank you for making the effort. I really appreciate it. It's good to see some friendly faces. So thank you again for inviting me to your beautiful country and state. And I figured I would start with a picture from where I'm from. So the picture on the screen is Salt Lake City, Utah. And this mountain range is the closest and tallest. This is Mount Olympus, and it's about 9,000 feet, so that'd be right around 2,700 meters for you. But I really like this picture because it's a little bit of an ominous, mountain view. One thing that we're known for in Utah is great snow. And so we had the Olympics in 2002, which was quite an event for us. Okay, so as Wendy mentioned, my name is Thomas Reese. I have a clinical degree in pharmacy and a research degree in biomedical informatics, where I did focus on the human-computer interaction. So my talk will be on how design thinking can put theory into practice. So I'm going to show you how I have and continue to use this iterative process of prototyping and testing to attack some pretty difficult healthcare problems. So at the end of this talk, I want you to leave with just a couple ideas. First, that behavior combined with data can increase the chance of better outcomes, and an appreciation for approaching complex problems with a process and not necessarily a solution. So being from the United States, and the idea that our healthcare system is tightly linked with the litigation system, I figured that I would start off with a malpractice suit where I was called in as an expert witness. So the plaintiff's daughter had suffered a fatal pulmonary embolism that was likely due to a medication she was taking. Now, the electronic health record had all the information that was needed to assess this patient's risk factors. And it also had generic information on the medication she was taking and the risks of taking those medications as well. Yet the provider and the pharmacist missed several opportunities to save this patient's life. So from this malpractice case, left me with some unanswered questions. The first was, why was the patient not more aware of signs of clotting? And the other was, why had the provider and multiple pharmacists overridden nearly all medication alerts? Is someone on there? Maybe a question?
It's probably not me.
Okay. Yeah. But really the dissonance from these questions was enough motivation for me to stop practicing pharmacy and pursue further training to try to help clinicians make better healthcare decisions. So shortly after starting my training, I realized that those questions from that malpractice suit were really targeted toward a behavior and were maybe symptoms of larger, more systemic problems. Which brings me to this gentleman, Horst Riddle. So he's a German theorist that mainly worked on engineering and policy-making problems. He coined this term, wicked problems, in the 1960s, which I think this characterization can help explain certain healthcare problems today. So Riddle defined these wicked problems as a class of social system problems that are ill-formulated, where the information is confusing, where there are many clients and decision makers with conflicting values, and where the ramifications of the whole system are thoroughly confusing. So to illustrate how healthcare problems, or certain healthcare problems, are wicked, I'll use something that's near and dear to my heart, which is clinical decision support. So again, tying back to that malpractice case, we pay a lot when litigation happens. So our clinical decision support is really set to be sensitive at that healthcare system level to try to mitigate some of this liability. However, this has unintended consequences. It leaves clinicians distracted. They also develop habits of overriding nearly all warnings. And so the patient has to live with the damages. The clinician is stuck with this liability, while the problem, the root of the problem, seems to be at the system level. So to me, the problems found in that malpractice case seem to be very much wicked. So to further clarify what I mean by wicked problems, these are some of those characteristics. So for every wicked problem, there's always one more, or there's also more than one possible explanation. For every wicked problem, it's a symptom of another higher level problem. Solutions to wicked problems cannot be true or false, only good or bad. And wicked problems have no stopping rules. And in solving wicked problems, there is no exhaustive list of operations. And then finally, every wicked problem is unique. So at this point, I hope you're starting to see that certain healthcare problems can be wicked. Now I'm going to jump into how I and others have approached wicked problems. So this brings me to another gentleman, Richard Buchanan. So he's a professor of design and innovation. So he linked wicked problems to design problems. Since in the design space, the problems are indeterminate because the designer really conceives the subject matter. So this makes sense, but what's helpful about linking these wicked problems to design is that these designers have a fairly structured process that really breaks them out of this conventional thinking to find good solutions without this expectation of the right solution. So this is one of those design processes. So the idea is that the process is iterative, reflective, consisting of defining the problem, understanding the users and the environment, ideating, reframing potential solutions, breaking down the solution, and then testing certain aspects. So the goal is to fail quickly and then redefine the problem, go through this process again until the solution is created. But all too often, those in our domain maybe don't have quite the appreciation for this iterative cycle. They tend to skip steps. So sometimes they'll define a problem based on limited information and then attempt to fix it based on convention or what they've done before. And again, tying back to that malpractice case, it's no wonder that up to 96% of medication alerts are overwritten, since clinician alerts are one of the most common solutions to changing behavior. And for those of us that do appreciate this process, our work can look like this, where we're aware of this process, but we get pulled around. We get pulled around by findings and limitations of the system. And so my experience in thinking is that scientific theories can help guide or bridge this process by providing us a starting point and some of these testable hypotheses. And this is really the primary point of my presentation. So most of you will know this, but I just want to make sure that we're on the same page. So a theory is as simple as an explanation of the natural world that has been repeatedly tested according to the scientific method. So it's a verified hypothesis. So Malinowski states that constant empirical verification, as well as original founding of scientific theory and experience, is obviously the very essence of science. So in other words, by using theories, we are putting science into our work. And I think this is a worthy cause and something that can be easily overlooked. So my logic is this. Many healthcare problems are wicked. And as others have done, wicked problems should be approached with a process and not a predetermined solution. And then finally, that theory or these basic truths can help guide the process of finding good solutions to these wicked problems. So for the remainder of this talk, I will demonstrate how I have used this process to create information displays for critical care, where I was focused on the health information technology and the artifact and the human-computer interaction. Then I'll show you how I'm using the same process to put theory into practice through health services research, where the information technology is just one of several components that will be implemented as a package to change behavior. Let's grab a drink. So as with any research project, it shouldn't be done in a vacuum. So these were my collaborators on this project. It was focused on the critical care information display. So I had a health services researcher, a health IT expert, a cognitive engineer, an intensivist, and a social psychologist. So this is a use case that motivated me to focus on critical care. So So happens to be my father-in-law's story as well. So just a few years ago, he had a successful coronary bypass surgery and was in good condition after the procedure. However, several hours after, his condition took a turn for the worse. His heart was struggling to keep his blood circulating, and despite various medications, he did wind up in cardiogenic shock. So as it turns out, he had an heparin-induced thrombocytopenia, which is an immune-mediated drop in platelets. So these platelets were essentially clotting on these newly grafted coronary arteries. Now there's a couple reasons why this condition maybe went unnoticed for a couple days. One is that he had rapid onset. He had had heparin from a recent procedure, and so the delay or the time from the onset was shortened. But also he was hooked up to a cardiopulmonary bypass machine that also depletes some of these platelets as well. So contributing to this atypical presentation, the intensivists were likely looking at an electronic health record similar to this, where you have a list of data elements on the left-hand side and then 9 hours of discrete values. And if, for example, you were looking for shock data elements, they're among other data that may not be relevant. And compounding this issue, where is the urine output, the lactate, the pH, the platelets? They're not on this screen. The clinicians need to go digging for these key data elements. And really the effort and cognition needed to combine these to identify trends could have contributed to how these clinicians missed this diagnosis. So what we know so far is that critical care is complex, and patients have overlapping and multiple conditions and little reserve for delays or misinterpretations for treatment. And unfortunately, errors like the one that my father-in-law had encountered occur quite often. And so I think that we can all agree that display or information display in critical care would be a really good problem. So I'm going to briefly go through each step of the process and give you just a peek into the theory that we used. So first, we needed to understand the space. And the way we did this was through systematic reviews of the literature. So we evaluated critical care displays in simulation and also that were implemented for patient care, and also displays that were for trend displays, or for trend information. So from the literature, we found that the best performing displays were on a single screen. They included graphical trend information, and they integrated patient information for pattern matching. So we started brainstorming derivative approaches based on our findings to see if we can meet these needs. So this first display is an object display. It's used to identify dangerous respiratory conditions. And what I mean by an object display is that the data elements such as inhaled oxygen and carbon dioxide are mapped to an object, such as the rectangle on the left and right hand side of this lung-like figure. But the idea is, as these related variables vary, it's easy to see changes or patient states based on the shape of that object. So this is another of those object displays. This one is for cardiovascular conditions. And again, the data elements such as central venous pressure and mean arterial pressure are mapped onto an object or rectangle type display. So these two object type displays, they do perform quite well on specific tasks, but they don't have trends, and they're not a whole patient view. So we thought something like this, where we have added trend information and then an object display as well. But the issue is this is also not a full patient view. You have some of these drop-down tabs. And also, this object display in the bottom left side is not integrated with this trend information as well. And then finally, this display was a full patient view. And I know this is difficult to see, so the point I'm really just trying to get across here is there's no trend information. But overall, most of these displays did perform quite well in simulation and some in patient care. So they would be, a viable starting place for us to start working towards. So we did some more thinking and some more digging and trying to figure out, which of these displays are currently used for patient care. And as it turns out, almost none of them are. So we tried to reframe this problem, trying to figure out, what is the issue?